Hello, everyone. Happy Friday. My name is Michael McNutt. I'm the Director of Education and Events for WEDI, and welcome to our virtual spotlight, Healthy Mothers, Addressing Algorithmic Bias and More in Maternal Health. A little bit about WEDI before we begin. Formed in 1991 by Secretary of HHS Dr. Lewis Sullivan in an effort to identify opportunities to improve the efficiency of health data exchange, and was named in the Health Insurance Portability and Accountability Act of 1996. We all know that as HIPAA. We are an advisor to the Secretary. Since that time, WEDI has closely interacted with every subsequent U.S. administration, including the current one, with its close working relationships with the Center for Medicare and Medicaid Services, Office of Civil Rights, and the Office of the National Coordinator for Health Information Technology. WEDI has the ability to influence all facets of health IT policy. Now, how do we do that? For example, we do that by bringing together more than 250 member organizations to drive industry consensus through our work groups and subwork groups, and you'll hear about that shortly, our task groups, our open public forums, our conferences and virtual spotlights like the one you're attending right now, and our member position advisory events. WEDI members represent every facet of the nation's healthcare industry, including practitioners, hospitals, health plans, laboratories, government entities, vendors, standards organizations, and many more. Our mission as an industry convener is to provide multi-stakeholder leadership and guidance to the nation's healthcare system on how to use and leverage the industry's collective technology, knowledge, expertise, and information resources to improve the administrative efficiency, quality, and cost effectiveness of health information. If you'd like to learn more about WEDI, please visit us at wedi.org. I mentioned the work groups just a second ago. These are these fantastic volunteer groups that are the lifeblood of WEDI. They provide thoughtful leadership and common sense approaches that enhance the exchange of clinical and administrative healthcare information. They collect input, exchange ideas, and make recommendations that inspire impactful and far-reaching change in our industry. Visit our workgroup community homepage at wedi.org to learn more and sign up. Now, there was one work group you didn't see in that previous slide, and we'd like to give it a special spotlight here. A brand new work group to WEDI, our Health Equity Work Group. The purpose of the Health Equity Work Group is to provide a forum for the discussion of health equity, social demographics, and social determinants of health, SDOH, with the focus on improving the equity of healthcare delivery and payments. We focus on business processes and workflows for the capture, exchange, and analysis of health equity, social demographics, and SDOH data, evaluate business cases, return on investment, data exchange, and overall impact of health equity, social demographics, and SDOH in healthcare delivery and payments, considering the perspective of our multi-stakeholder folks, our providers, our payers, vendors, individuals, and populations in the review of health equity, social demographics, and SDOH. And finally, to promote a broader understanding of the impact of SDOH and social demographics on health equity. This is just starting out, so we're very excited about this work group, and we're constantly looking for additional ideas, topics of discussion, and perhaps even content that we can use for our podcasts and our conferences and our spiritual spotlights. As you can see, our co-chairs are on the right of the slide. And to join, if you're interested, this is for WEDI members, please contact Samantha Holvey at sholvey@wedi.org. If you are not a member, welcome, and we would love for you to be a WEDI member. Please contact Bill Alder at BALLDER@wedi.org. He's currently in the chat. I'm sure he's going to throw his email out there real quick for you. So if you're interested in learning more about WEDI, Bill's the man to talk to. Before we begin, it's my pleasure to introduce our two speakers. Holly Varnell, co-founder and president of Dream Big Health and executive chair for Dream Big in Maternal Care, and Dr. Sharon Hybe, CEO and principal of Advanced Health Outcomes, LLC. Additionally, for any questions during the spotlight, feel free to use the chat function on your Zoom during and after the presentation, and we'll be sure to read those out, and hopefully Holly and Dr. Hybe will be able to support and assist you. Now, without further ado, it's my pleasure to introduce Holly Varnell and Dr. Sharon Hybe.
Hi, Michael. Thank you for the introduction. I know we're going to keep some of these intros short, but just a little bit about myself and kind of why I and Dr. Hybe are really focusing on maternal health specifically is I know that we're both very passionate about reform and how we look at and deliver healthcare and how we can start to change some of the really large disparities that we already know exist in maternal health. So hopefully we can give some insight on how we can do that, both from a policy, payment, and also a technology standpoint today. And Dr. Haibe, I'll let you do an introduction, then we can jump in. I believe you're going first with some of our presentation.
Very good. This is Sharon Haibe. I'm very happy to join you. I'm a clinical quality measure developer and accountability expert. I'm not sure if everyone's able to hear me and see me. I have a little tiny bit of difficulty sharing a slide, so give me 2 shakes to do that.
And yes, Dr. Haibe, we can see and hear you. So thank you for checking for that, because I've definitely talked on and been on the mute and not even realized anything was not coming out audio-wise. So thank you for checking. And let me know if you need anything on the slides.
Yeah, I'm having a hard time forwarding my slides. I'm not sure, Michael, if you're able to do that.
I'll be able to pull them up and you just let me know when I can advance. Give me a second.
Okay.
It wouldn't be a true webinar without some technical difficulties. Right?
Isn't that the truth?
Slides are up.
Okay, that's wonderful. Do you mind going to the agenda slide, please? Perfect, thank you. So today, our agenda for the webinar will be to discuss some maternal and infant health statistics, talk a little bit about guidelines and some general findings of care delivery. We also want to talk about health equity from a policy alignment and value-based care delivery perspective. We're going to define some equitable data, talk about maternal health and some recent technology advancements. We'll talk about AI, also algorithmic bias. I think that was kind of the headliner that we want to discuss today for sure. We'd like to get into some FHIR HL7 solutions and other innovative technologies that are on the horizon and being advanced as we speak. And then in addition, we're going to talk about some next steps for the future. Okay, next slide, please. One back, please. All right, well, you know, being the nurse researcher, I'm not going to not start off with some data. So I always believe it's a good idea to steady state us with where we are in the aspect of whatever the condition is. And obviously, we're talking about maternal morbidity and mortality as well as infant morbidity and mortality. So, you know, I'm going to show a slide here about maternal statistics, and then we'll jump into infant statistics. So what I'm trying to depict in the graphic here, just as in the last published data that we have for 2018 to 20, is just look at that continued rise in maternal mortality. There's a lot of national attention on this, and you know, it is certainly a national priority. Here you will see data that represents not only the years, but it's going to look at the mortalities themselves, as well as looking at mortality rates per 100,000. And, you know, just in general, we continue to get worse every year. Some of the data from 2020 may be impacted by COVID and the access that people had to healthcare, et cetera, but it's not pretty out there. We need to be addressing this now. We need to decide that now's the time. As far as morbidity is concerned, or severe complications, what we think about here, this is a list from CDC of the top 21 complications that mothers have during or after birth. So they're pretty significant. There's right now about 50,000 or more, probably more, severe maternal morbidities that occur each year during the delivery hospitalization. And then in addition, we find in our last presentation, if you had an opportunity to listen to it, it's really quite interesting. It really focused a lot more on preterm birth specifically, but 80% of all of these complications are preventable with routine prenatal care. Next slide, please. Now, as I promised, here's some infant mortality and morbidity statistics, and I should let you know that October is infant pregnancy and infant loss awareness month. 1 in 4 babies will die of miscarriage, stillbirth, or infant loss within 1 year of birth, often by the 5 leading causes that we have here. Birth defects and preterm birth themselves, those often occur as numbers 1 and 2 without any other complications known, meaning that this is the first thing that they find, the first complication, and that's the reason for the infant death. And here again, I show you some data here related to race, and you can see what you see in every statistic that is mentioned is that non-Hispanic Blacks will have more morbidity and mortality from the mom's perspective, from the baby's perspective, from an access perspective, from all kinds of outcomes perspective. And we need to address these. Next slide, please. Okay. I'd like to talk a little bit now also about health equity in general. So health equity is defined as the ability to obtain optimal health through access to high quality and affordable care for all. Social determinants of health themselves are those factors or conditions that impede one's ability to achieve health equity. Everyone, all populations, all individuals should have the ability to obtain their own desired optimal health. Now, some of the things related to social determinants of health, also called social drivers of health, they're also called social risks, sometimes just drivers of health. You know, they can be healthcare specific related. They can be non-healthcare related and also quasi-healthcare related. Now, healthcare related are kind of obvious. There are healthcare policies, whether or not a patient has access, and also explicit or implicit in bias. And we'll talk a little bit about that in a minute. They can also be non-healthcare related, like financial stability, what level of education they've attained, et cetera. But then you have those I call them quasi-healthcare related. You know, those are kind of in a gray area. You might think from looking at them initially that transportation and food security, well, they don't sound like they're really in the realm of healthcare, but healthcare has absorbed a lot of those, in some instances have absorbed a lot of those other drivers of health because they have been demonstrated to have such an impact on access, quality of care, and outcomes. So those specific ones also, you'll see, will become the focus of some of the work we talk about related to the Gravity Project, FIRE, and data, et cetera. When I think about health equity and maternal care very specifically, I question, I'm going to ask a lot of questions, whether or not our current healthcare delivery model is designed to improve health equity. Do we think it's person-centered? Does it person-centered itself must focus on health equity? You can't consider health equity and be person-centered. You can't be one without the other. Is it designed to accommodate for drivers, for diverse drivers of care, such as demographic, clinical, social, geographic, cultural, community, and practice characteristics that, again, impede or improve access, quality of care, and outcomes? So that's really a big old mouthful, that last question that I have. And we know the answer to all of these are no, I hope. So we want to think about how is it we need to be delivering care, designing care, paying for care, and collecting data so that we understand that we're measuring care that patients want. Well, a couple of additional facts to share with you. 1/3 of all moms show up for their first prenatal visit at the time of birth when they're in active labor. A recent ARC study, Agency for Health Care Research and Quality, showed that 42% of moms do not believe that their provider cares about the health or the outcome of them or their baby. We also believe that not accurately capturing what is actually happening in care delivery limits the ability to really change care. We have data that we're collecting related to care delivery that's not accurately reflecting what is boots on the ground. And then there's other pieces of care delivery that are often challenging. And we'll talk a little bit more about those as we move forward. Can you move to the next slide, please? So this is related to maternal care. These are maternal deserts. So what this map basically shows you is a woman's access by geography in her county to maternal care. So black is they have those areas are full closure. And so then you have continual services, and then you have no services. So these are pretty, so people in these areas have limited or no access to maternal care. Fewer than 50% of rural women have access to perinatal services within 30-minute drive of their homes, and more than 10% of rural women have to drive over 100 miles to receive maternal services. Next slide, please. So I'd like to talk a little bit about value-based care and how that has driven the data policy. So in this day and age, I think we all know what value-based care is. It's the incentivization, a financial incentivization of outcomes and costs in defining value in care. Predominantly, value-based care takes a look at how costs, with some mix of measures that are scantily assess the performance of care delivery and maternal care. And so we want to get from a shift as we move forward from looking at cost as the primary driver of value to looking at person-centeredness, again, which incorporates health equity as drivers of care. So our challenge is to create a maternal value-based care delivery model or models that is person-centered, focuses on health equity, and incorporates a whole gamut of factors, again, that drive care. You can see all of these when you start thinking about from a cost perspective, when you isolate value-based care assessment to almost predominantly cost, you're limiting quite a bit of the true drivers of care. Next slide, please. I want to also talk a little bit about, in general, about the state of care for women of color and just in general, but more specifically in maternal care. Both women of color and maternity care providers state that they're very challenged in our fragmented healthcare system to provide care that builds trusting relationships and supports patients and families building childbirth experiences that have them feel autonomous and are represented in spaces of dignity. Personal autonomy, of course, has to also incorporate the fact that we need the mom to be safe, we need the baby to be safe, we want them to have good outcomes. So sometimes birth plans change based upon the clinical presentation of both the mom and the baby or the baby. Women of color routinely report instances of race-based explicit bias, discrimination, including verbal abuse, poor communication, neglect of reported needs, and even sometimes rough treatment. Patients are not feeling safe or respected in hospitals, as well as networks not allowing support partners during the pandemic. Both of those instances have contributed to increases in community births in the United States. I think that it probably just goes to say, it's kind of obvious, but I think it's important to point out that the combination of shared decision-making and patient preferences that appeal specifically to mothers are integral to creating positive birth experiences. And when a mother feels safe and their family feels safe, and respected, and their preferences are being attended to, that leads to patient safety and also creates safe birthing environments. So while we were doing our background search for this presentation, I came across an article from 1985. And basically it stated that it was called Maternal Mortality, a neglected tragedy. That was 40 years ago, 1985. This trend continues as the data demonstrates above. So we have for a long time been devaluing, deprioritizing the need for women, and especially women of color, to be able to receive care in a dignified, respected, and safe manner. One of our tech chairs is a woman named Ashley Randolph, and often talks about her care that she received. She had 3 high-risk pregnancies, and we discussed this very briefly as well in our last presentation, but basically the care that she received initially wasn't care at all. She ended up being fired by her providers because the care itself did not want to assume the care providers did not want to assume the high risk that she had for her care delivery. So she didn't even have access to care at all for herself or for her baby. Next slide, please. Okay. So health equity and maternal care, we know the guidelines right now are lagging behind what women want in care delivery, what reimbursement allows for, and or if reimbursement does allow for and policy does support. In all instances, we're not seeing maternal care delivery up to date and aligning with what those patients' needs, preferences, circumstances, and social drivers are. Women of color often everyone wants care that is person-centered. We need culturally diverse care. We need centering care, which basically is providing care in groups where women feel like they are supported and they're not isolated and alone. They want their voices to be heard. Having doulas that support and listen to what the mom wants. Self-scheduling of prenatal care is very, very important. Having rigid timeframes where people can meet, that challenges moms often. Telehealth, there's gifts and challenges to telehealth and maternal care, but we need to think about telehealth and how we can utilize it judiciously to support what care is appealing to women and accessible to women. Care journey mapping and other technologies are demonstrating themselves as being very beneficial to moms. Home and water births, also asynchronous care. Women don't always need to meet with a care provider to receive care. What can be done offline, so to speak? And what additional social supports do they need to make sure that we are assessing what their needs are that help them get to a healthy end, a healthy outcome for both the moms and the babies. And I want to talk about a few other things as well. We find that clearly care delivery right now, you don't hear a lot of how care delivery is aligned with this nice, robust list of things that appeal to women and how they would like maternal care to be designed. And then there are some other aspects as well. Family dynamics, family participation in care. Of course, we know COVID challenged that. We talk about child care gaps. That can be often a challenge to women, to all women and women of color. And also interpersonal safety and violence. How do we manage that within all of the care needs as well? What is very important right now is understanding maternal health care needs, not just postpartum depression, but anxiety and isolation that happen for moms during pregnancy. That's where often centering care can provide those types of support. And last, I want to talk a little bit about substance use disorders. And we find that actually for maternal mortality, Substance abuse is the #1 reason for maternal mortality. So how are we addressing this in maternal care? We don't hear a lot about that, and we don't see a lot about how that is incorporated in care delivery. So I want to kind of share with you a vignette. I want you to think about women's care in general, which is often not prioritized. So I shared with you the Lancet article of 40 years ago on how we needed to think about this maternal care tragedy that can be ameliorated, and 40 years later we're still dealing with it. Think about being an African American woman who doesn't have health care or has limited health care. Maybe this person has other comorbidities that are compromising her situation. She has a significant amount of social determinants that might be there, and then put her in a rural area where you don't have access to care. So oftentimes when we think about health equity in care, we will measure it on a measure by measure basis, but we're not really thinking about that patient, and we're not thinking about compounded health equity concerns, right? You have compounded vulnerability when I present that type of vignette. And then the next part you want to remember is that compounded vulnerability is not just to the mother, it's to the mother and the baby. She's carrying one along with her. So we want to make sure that we can really decide which time to prioritize maternal care. Next slide, please. Okay, in value-based payment models, just in general, the nuts and bolts of value-based payment models can be quite complicated, and there's payment models and payment arrangements and various measure programs and individual measures themselves. And health equity is embedded in like this spider diagram kaleidoscope of ways that are often confusing, and we don't often look to try to find the connections and antecedents to all of those. They can be in the models themselves. They can be in model rules or requirements. They can be in risk sharing agreements, participation requirements of providers. They can be in incentivization calculations. They can be in patient inclusion and exclusion criteria. They can be specifically in measures themselves. We don't really routinely require measures to have performance be reported by any type of social indicator. We'd like it, but 4 decades later, we're still grappling with that. And also in measure risk adjustment themselves, how measures take a look and they say, oh, I want to adjust for and try to normalize populations based upon their various types of risks. So I'm going to give you just 3 quick examples, and I'm going to pass it over to Holly to move on. So this Center for Medicare and Medicaid Innovation, CMMI, they're the kind of like the people that run the show as far as value-based payment in CMS. They took a look recently at 3 different value-based care models and described how implicit bias. Implicit means that it's built into the structure as I have them defined here on the screen here, into the care models, rules, requirements, risk sharing, etc. And they tried to understand how this implicit and bias was built into these. And so they were just looked at a couple of models. So they have a kidney care model. So if you think about kidney care, so it's very high in the African American and Hispanic populations. Kidney care is because they have renal failure, they have high levels of diabetes, etc. And so this model itself uses a clinical risk algorithm that risk adjusts clinically in an inappropriate way and puts the de-emphasis on African Americans as far as their severity of illness. Well, just by the clinical selection alone, that biases that population, delays their care that they might receive from a specialist, as well as possible kidney transplant referrals. That in itself is an implicit bias that must be changed. The comprehensive care joint replacement model, again, all 3 of these models affect African Americans so significantly. it wants you to include patients who are less medically compromised, and they would prefer to not have dual eligible, meaning they have Medicare and Medicaid patients, and safety net hospitals as well. And patients with greater social determinants of health are also kind of excluded or have increased disincentivization or have more financial penalty when included. So that in itself is like a selection bias. So again, another implicit bias. And then the Million Hearts cardiovascular risk model. It looks at both African American to Caucasian and Asians, and it looks at just in general, when is their onset of cardiovascular disease and some of the other cardiovascular risk algorithms, which also underestimate African Americans with greater social determinants of health. Again, it's just how is it we're looking at the work that's out there, value-based care, all of the infrastructure, and saying we really need to build structure and systems that are assessing, is value-based care improving or is it impeding opportunities for improving health equity? Lastly, I want to just talk about a couple more things related to health equity. You know, we're doing a lot of work lately on new measures. There's some new morbidity and mortality measures you're going to see in the future related to obstetrics. One is on severe maternal morbidity, which are, you know, just complication rates, and cesarean births. There's new social determinants of health measures that are on the horizon. And then also we want to think about how is it we can start to get our infrastructure itself to develop formalized and systematic structures that assess health equity throughout their various value-based care model parts, whether or not they are the care delivery models, the requirements, etc. Lastly, what I want to leave you with is, and this section is all of this information. Holly's going to talk about a lot more about data and the requirements and such. We have waited in maternal health for a long time for care delivery to be modified. And also in general, we are waiting for perfect data and standardized data, comprehensive data to move the needle forward. I suggest that we try to move the data and infrastructure forward, as well as we move forward with improving care delivery for moms and babies. Holly, can I turn it over to you now?
Hi, Sharon. Yes, you can. Michael, if you wouldn't mind forwarding the slides, just one. And I tend to talk very, very fast. I'm going to try to slow it down and pause, but I want to give us time at the end to have some questions and be able to answer some of those for you. So feel free to jot anything down and I'll be happy to address it at the end during our question and answer section. So one thing that Dr. Habe has been pointing out throughout everything that she's been presenting is the focus on needing to have advocacy and needing to bring awareness and needing to have the right stakeholders at the table to ensure that we actually can succeed in any of these new clinical quality measures or any of these new policies that are being enacted right now. And a lot of those stakeholders really get down to the very ground level. We want to get perspectives from mothers, community members. We want to get health equity and maternal and neonatal advocates. We want to get our obstetricians. We want to get government institutions on board, the state Medicaid agencies on board, and really start to look at what it is we can do to start to at least attempt to try to fix some of these disparities that we know exist. Next slide, please. So that's where Dream Big Maternal Care. So how all of this really started, and if you guys were on here a little bit earlier listening to our first WEDI podcast, and thank you, Michael, for setting that up, about Dream Big Maternal Care, this is kind of where it starts. So we do want to focus on what the experts want. Sometimes we try to get into, and I will shortly get into how we can fix things or these cool new things that we can add in technically, but first we need to look at policy and payment and see if there's anything hindering the adoption of some of these new technological advancements that we have. So with Dream Big Maternal Care, we created an initiative called Driving Equity for All Moms and Babies by Improving Gaps. And it really focused on creating actionable clinical quality measures that would change the way that both patients and providers received care proactively to try to reduce some of these disparities early on. And having some of these experts on board and really looking at and picking apart these clinical quality measures, which was amazing and is amazing. It also allows for, workflow adoptions. If we have these key stakeholder leaders that are saying, we need to start using this or adding this technology to our electronic health records, or starting to think about this from a different perspective, that's really what will ensure our success in implementing some of these new clinical quality measures as we continue to develop them. One thing as we start to get into the rest of the information throughout the rest of the presentation to think about is a lot of times we get confused by equity and equality in healthcare. So equality, we look at providing the exact same resources across the board to all populations. But what we really want to focus on is health equity. And equity is more about making sure that the patients who need specific care get the specific care that they need, and we meet them where they're at. So we're not providing the same resources and the same care across the board. We're providing the resources that each patient needs. So we're truly focusing on patient-centered care and really incorporating the voices of the women in our maternal health care to make sure that we do solve some of those issues that were related just to socioeconomic and geographic and other types of factors that attribute to some of these outcomes. One of the things that we tend to do too is look at, the wider picture, focus on the 80% of the population that we can actually start to move the needle with, when we really need to start looking at that 20% that have, special needs or have the most improvement to be gained or can create the most value. So we do want to start to kind of zone in and drill in on things like, are some of these preemie babies that are being born, do they have special needs, and do they continue to have special needs throughout? Are they getting the care that they need through their Medicaid state agencies? There's not a lot of Medicaid providers. Well, I would say there are a lot of Medicaid providers attempting to provide care to these patients, but it gets limiting. There's a lot of administrative burden that goes on there. So we want to be able to focus on some of that and be able to reduce some of that administrative burden while making sure that we have the right care for those patients that are often overlooked. Next slide, please. So now we get into the fun stuff, at least for me, the data nerd in myself. So how do we start to incorporate data, and how do we start to move the bar equity-wise with some of this data that we can start to get out of some of these new regulations that are coming out and some of the new initiatives that are being enacted? So one thing to point out first is we want to start to look at data with a little bit of caution, because we can have data and we can draw a lot of information from it, but we want to make sure that the data we're starting with is the right data, it's structured, it's correct data, and that we're applying it across the board. One of the most important aspects of looking at data when we're starting to address some of these equity concerns is making sure we're incorporating patient-reported data. We really need to see at the ground level what it is that are affecting both clinically and non-clinically different phenotypes or attributes that are adding to what some of these new points of care can be, and being proactive with trying to prevent some of these outcomes, and then starting to find some of the root causes of what these outcomes are. Just as importantly, the clinical or electronic health record data, we can draw inferences from that at the same time, mix it with our patient-reported data, and really start to kind of look at where we can find those new points of care. But some new data that is starting to get really, really popular right now is proxy data for trying to assess different regional attributes and the resources needed there. And then also synthetic data. So if you're worrying about electronic patient health information, this is redacted data or not associated patient data that allows you to start to run some of these new machine learning algorithms that are coming out on a vast database to make sure that it is reproducible, functional, and feasible to incorporate. So again, proceeding with caution, we want to make sure that, yes, we want to start doing this early technology adoption, but we want to make sure that we're not adding to the root causes of the healthcare disparities to begin with. Because if we look at data, only for a subpopulation, then that's not really realistic for what it is that we're trying to fix for the whole population. Next slide, please. So this is kind of interesting too. So we talk a lot about health equity and being able to implement a lot of telemedicine policies. And telemedicine is going to be a wonderful solution, but some things to keep in mind, again, data with caution. When we start to look at this data, for example, I have on the left-hand side what the broadband internet availability is and access to that availability is in US counties with over 50% rural populations. And you can see that yellow is considered poor, so it's 0% access all the way up to good, which is 100% access. And you'll see here that there is a lot of yellow in pretty large areas. And in comparison, over on the right-hand side, this kind of adds to the problem. And one of the things that we need to start looking at and focusing on to add to some of these telemedicine and community resources is the exact same map showing that US counties with greater than 50% of rural populations also have the least access to physicians in primary care. So they're the ones that really need the ability for that telemedicine. So we just need to start looking at, you know, a little bit of bandwidth concerns instead of just saying, oh, well, everyone has smartphones. Well, everyone may have smartphones, but they may not have the ability to full on have a video telemedicine visit with it. Next slide, please. So really awesome stuff that's happening with maternal health and technological advancements. Now that we got over kind of the caution stuff, we can get into some of the really cool stuff. So with the 21st Century Cures Act and some new EHR requirements for 2023, we will see a lot of new, very hopefully, a lot of new applications popping up and a lot of ways that we can start to integrate those with our current healthcare technologies. One of the things to point out, just to be aware of, is when we are starting to implement some of these new applications that can drive a lot of clinical decision support and diagnostic tools and prognostic tools, we want to make sure that it harmonizes with our current technology, because we start to implement this at the high health system level. When we get to the providers and it's a completely new training for this new technology, a lot of that can be reduced if you start to look at different technology, what it actually adds to your clinical workflow, and then making sure that it is similar in functionality as far as how it harmonizes with the way you use your current healthcare system technology and some of these new applications. Some of these applications can function a lot in the way as your current healthcare system, so it reduces some of those training necessities. Also, we'll see with our US CDI information that's coming out, we have currently on version 3 and coming out looking forward at version 4. There are some efforts for submitting pregnancy information data class elements that we can start to really add in ways that we can structure, standardize maternal health data in the electronic health record. So we will see these new data elements and ways to put in clean, accurate, structured information. But one thing we need to be aware of is, again, that workflow adoption. So we may have all of these new ways of linking. So for example, with one of the new FHIR attributes, we have the ability to link different elements. So we could link the baby to the mother. And there's a lot of other policies that go in place that we need to be aware of when we start to talk about that. But it gets really exciting on what we can start to do with some of these inferred relationships. And then we start looking at what is actually being required of these new applications and electronic health records in 2023 and the open access to patient information and group pools. And we can start to mix some of that patient-reported outcome data collection with some of these new maternal healthcare focused data elements that we start to utilize and start to build some real inference with relational attributes on what we already know. We can add to, you know, what it is that we can actually fix or what it is that we can actually change or even uncover things that we haven't even thought of before. So a lot of really cool stuff coming out with FHIR, HL7 FHIR. And one of the projects that has been focusing on this is Gravity, and they are really awesome in that they are including a lot of social determinants of health in this FHIR data. So we do have non-proprietary value sets that are linking social determinants of health to maternal health care, and it's now available to be structured in standardized data that FHIR can pull and push with the new requirements for patient-facing data and group pools. So a little bit of nerd information there, but some cool stuff. Next slide, please. So again, get a little bit excited. So if we start to think about this, we can start to really look at how we can use machine learning, natural language processing. I hate to use that word because I like to only use structured data and not kind of have that inference with just chart notes. But we can start to demonstrate different maternal health risk stratification tools. There was a recent white paper that just came out that showed the preliminary results were very promising on being able to use some of these different attributes and create these maternal health risk stratification tools. And now that we have the requirements for patient data pools, we're going to see hopefully a lot of patient-facing apps. So it kind of removes that burden of the integration cost with electronic health records and getting their consent to start to gather all of this data from different disparate data sources and start to combine it and really start to learn more, and plus allow for the true interoperability between different systems. So every provider knows exactly what's going on with this patient's clinical history and their current clinical symptoms, so they can start to accurately move forward with some of their medical management. So again, we've got a lot of technology to be adopted. There's a lot of cool stuff. There's new biosensors that are out that can start to monitor from the home the prenatal behaviors or different symptoms or different risks and give that proactive information to the clinician to start to look at things earlier on. But it also is for the patient too. So there are going to be a lot of applications, and something at Dream Big Health that we're actually working on too is coming up with some of these items, is providing ways for self-checks and at your home. And that self-check can be shared with your clinician, or it cannot. It's up to the patient, because everything's about patient-centered data now. So having a lot of mothers that, feel like maybe they've been medical gaslighted and they know that there's something wrong in their gut and there's something there. This is that reassurance or that confirmation sometimes that they need to seek out additional medical intervention. Next slide, please. So getting into kind of what it is, and I believe this is actually in the title of the spotlight, but one thing that is happening with all of these new applications coming out and the open access and patient availability of data is, unfortunately, with some of the really cool stuff, we get these new challenges as well. So again, proceeding with caution. We have a lot of cool new tools, but let's make sure that we're applying them the right way and not reinforcing some of those disparities that we already have. So it's going to point out a couple of different types of algorithmic bias and artificial intelligence AI machine learning tools for some of these new diagnostic apps that are coming out and soon to be coming out. Is we can look at algorithmic bias in a couple of different ways. One, on the left-hand side, you can see what I try to demonstrate here is when you're going in to provide clinical validation for a diagnostic or prognostic or any type of software as a medical device tool, you have a specific training cohort that is relevant for that population. We want to make sure that the training cohort that we're applying some of this machine learning algorithms to and testing that feasibility and functionality and reproducibility is applicable to who we're actually applying it to. And there will be some standards and some labeling that will allow us to kind of see what those training cohorts are, so we can start to determine whether or not they're applicable to our specific patient population or this regional patient population, but we just need to be aware of that. And another thing to start to look at, there are a lot of risk stratification tools that take into account the disparities that already exist across vulnerable populations. And this, it really does add a pretty big complication in what we're trying to do as far as not forcing some of these disparities to start with. So if we are applying machine learning algorithms to tell risk stratification based on what previous outcomes were without looking at the root causes of those previous outcomes, we're just continuing to further that, because let's say for cesarean sections, for example, we know some of the outcomes for cesarean sections in vulnerable populations. So we may reduce the amount that we use cesarean sections, vice versa, in different populations, which will just further the complications that can come along, or again, vice versa, with cesarean or not cesarean. But the point is that if we look at the outcomes versus what are the root causes, we continue to push what that disparity already is and what we know it is. Next slide, please. I'm not going to leave a lot of time for questions, so I'm going to rush through this last little part. So there's a lot of new technology. What's amazing is a lot of this awareness for maternal child health, care delivery, and transformation is driving this new technology. And there's a lot of initiatives backed by the White House, backed by the National Institutes of Health, and a lot of different entities that are promoting this new technology. Next slide, please. And this again, so we started to talk about dream big maternal care, and just to kind of wrap up here, because this is something that I think is we need to look at as we start to see some of these new emerging technologies, is we're having a lot of these technologies come into the market, but a lot of times, unfortunately, they come in with, you know, a commercialization aspect, and they fail to look at their go-to-market strategy. And that really is their entire, you know, the factor that they can succeed on is whether or not they have market adoption and whether or not they have reimbursement. So Dream Big Health was just an evolution of Dream Big and maternal care, focusing on a more expanded population, just providing equitable care and access to medicine across other vulnerable populations, and ensuring that some of this new technology that is coming out, that we're giving them the go-to-market strategy and giving them the ability or the chance to succeed as they're coming into what's going to be a really busy emergence of some of this new biotechnology. On top of that, we're working on making sure that they are addressing algorithmic bias, and we're also starting to create some of our own digital diagnostics that can hopefully start to address some of these maternal health equities very soon as well. Next slide. And sorry, I didn't see it click there. So looking towards the future, there are going to be a lot more items coming out. I'll let Dr. Haibe get into a little bit of hers because I want to save time, but we have a very promising future that we're looking towards, and all of the new technology that's come out thus far is just going to continue to come out. So we need to, one, be excited about it and then proceed with caution at the same time. Dr. Haibe, I'll let you wrap up with a couple of minutes, and we're leaving like 5 minutes for questions. So we might just want to.
Thank you, Holly. Thank you, Holly. I just think let's just move on to questions. I think the information on the screen is pretty explicit, so maybe we could leave that on there for a second, Michael, and then you know, and then move to the question slide. If there are questions, we're happy to entertain them.
I love that we left 15 to 20 minutes of questions, and you and I get so passionate that we try every time, and sometimes it works out.
Thank you, Dr. Haibe. Holly, for the audience here, do you have any questions? Love to hear from you. Please feel free to enter them in the chat. If there are no questions, Holly, Dr. Haibe, please, I'll leave the floor to you for any closing thoughts. Oh, there is a question here. We have one from Samantha Holby. What are you most excited about for maternal health in the future?
You want to take a stab at it first, Holly? You want me to go ahead?
Well, I can make mine pretty short. So really, it's being able to now start to have this standardized structured data and be able to start to build some of those inferred relationships and be able to find some of those new points of care and new things that we can start to do to proactively prevent some of these outcome disparities.
Yeah, and in traditional form, Holly will talk about it from a data perspective, and I'll talk about it from a practice perspective. I think the biggest biggest exciting piece of all of this is that our experts that we assembled want to redesign maternal care. They know it's not, quote unquote, fit in the bill. And so how is it we can make sure that as we think about what we want care to be, we are engaging the community throughout this entire process, starting with the TEP, but it'll go much further than that. How is it we can, you know, really take this moment to say, now's the time, what do we want, how do we envision it, and then utilize this as an opportunity to engage with all of the other infrastructure, fire, all of that good stuff to make sure our policies, our infrastructure align with what our person-centered driven care could possibly be.
Excellent. Michael Patwell has a question. Have you seen any of the new CMMI ACO REACH participants addressing maternity in their health equity plans? My understanding is each participant needed to submit a plan for approval.
That is correct, yes. And so I have not seen specific maternity related applications of information that is out there. But, you know, in general, you know, we will see some, and we will be able to use those as a pool of opportunities to possibly move forward based upon payer and provider and all of those other social and demographic, et cetera, risks, practice characteristics as well. I think that it wasn't specifically built around certainly maternal care, but we do know as OBs are often seen as primary care providers, we should get some robust information out of them.
Thank you. A couple more minutes for any additional questions. Yes, groundbreaking work indeed. Okay. Dr. Hybe, Holly, I'll let you have the final thoughts.
Well, I'll just go ahead first, and then Holly, let's round it out with Dream Big. So, you know, thank you for your time today. It's very much appreciated. As the clinician measurement person, I feel like a little cheerleader on the side, often saying, can we listen to our patients? Can we listen to our providers? Can we let the needs of those two aspects drive how we want to move things forward in the future? And so whenever you're engaged with me, I will always ask those same questions. What do the patients want? What do they need? What do the providers want? Where's the burden? Are you fairly assessing what care delivery should be? And value-based care is not a cost initiative. It must be an initiative that assesses the whole person. It must be an initiative that assesses the entire value-based community and the ecosystem itself. Holly?
Yeah, I'll just finish it up. I put a few links in the chat box for if you guys think of any questions later on, and any for Dr. Hybe, I can forward those on as well. And if you want to get involved either with just giving your insight, we are always very, very open to gaining new perspectives. I did put a link in there that you can contact us at. I always love hearing about new perspectives on things and ways that others kind of see addressing some of these issues. So please feel free to reach out with any of that or any questions or anything else that you may need.
Excellent. Thank you so much. Holly Varnell, Dr. Sharon Hybe, thank you once again for this fantastic virtual spotlight looking at maternal health. We welcome your return sometime near soon, whether at our podcast, a spotlight, or our conferences that we hold. For everyone still on, visit us at wedi.org for more information about our educational offerings. Thank you very much and have a fantastic weekend.
Thank you, Michael.